So the topic allotted for me is the role of physiological pacing for heart failure. So what exactly is physiological pacing? It's nothing but direct pacing of the cardiac conduction system. So we'll be pacing either the his bundle or the left bundle branch directly using a small sized specially designed lead to capture the cardiac conduction system so that there will be a synchronized activation of both the ventricles, and there could be a possibility of reduction in the incidence of pacing-induced cardiomyopathy. We all know that chronic RV pacing is going to produce electrical as well as mechanical dyssynchrony. So that in turn is going to produce LV dilatation, LV dysfunction, atrial arrhythmias, and recurrent heart failure hospitalizations. So this conduction system pacing, or otherwise known as physiological pacing, is going to reduce all these complications. More than that, in this particular topic, we are going to discuss its specific application in the role of management of heart failure. Of course, it is nothing different but a simple dual chamber pacemaker, but for two important hardwares. So we'll have to have a sheath separately to deploy a specially designed lead in the his bundle or the left bundle. So currently in India, there is only one sheath available, but as it's available in the market. So one is a non-deflectable one, and another is a deflectable one. So we don't have the deflectable one till in India. The lead is a small sized 4.1 French sized MRI compatible lead. It's labeled as 3830 lead. So the beauty of the lead is it's an isodiametric lead, and the helix is open so that you have to rotate the whole lead to deploy the lead either in the his bundle or the left bundle. Of course, we need to know fluoroscopic anatomy of the cardiac conduction system to do either his bundle or left bundle pacing. So I always choose an RAO view to know where exactly the his bundle and left bundle is. So we always keep two catheters from the groin. If you don't have an EP system, just place your RV catheter in the RV apex. So this is how the fluoroscopic anatomy of a conduction system will look like. This is your his bundle, and this is your right bundle, and this is your left bundle. So if you are planning for doing a his bundle pacing, your lead will automatically go there, map for the his signals. You know that there will be a sharp deflection in between atrial and ventricular signals. That is nothing but a his signal. So you have to target that if you're planning for a his bundle pacing. But if you're planning for a left bundle pacing, you have to go little below, probably 1.5 centimeter below the distal his bundle on the right side of the septum. Then you have to give rapid turns to deploy the lead deep inside the septum to capture the left bundle. The role of his bundle pacing in treatment of heart failure actually came from the concept of predestined fibers. So we know that the his bundle is a cord of fibers which have fibers going into either left bundle or right bundle. But the concept is many of the fibers are predestined to go inside either left bundle or right bundle. That means that if there is any segmental his bundle disease, that fiber, which may be either predestined for left bundle or right bundle, will be affected, and the patient will have either right bundle branch block morphology or left bundle branch morphology. That means that even an intraHisian disease can produce either LBBB or RBBB. So there comes the concept of correcting the LBBB or RBBB by pacing distal to the site of block. For example, if this is the length of the his bundle and if you have a disease proximally, segmentally, that has affected the left bundle branch fibers, then you just have to go little distally beyond the diseased segment, just like putting a graft to a diseased LAD, a Lima graft to a LAD, which is diseased at the osteal lesion. So you have to jump the diseased segment and place the lead distally to capture the diseased bundle. So here you can see the patient with the DCM LBBB QRS where his bundle pacing was done. You can see a beautiful looking QRS, and the ejection fraction from 30% has improved to 60% at the end of 2 months. Not only LBBB, even an RBBB can be corrected by doing his bundle pacing. So all you have to do is just map for the signals and just go beyond the site of block and pace the his bundle. You will be able to regenerate a normal appearing QRS. When you have a beautifully working his bundle pacing lead, so what's the need for left bundle branch pacing? There are certain limitations. If you see any article about his bundle pacing, we know that there is a chance for a lead dislodgement or lead revision. It's close to 10 to 15%. And there is a chance for rise in thresholds. Another 10% of the patient can have rise in threshold. You may be programming at a higher output, thereby depleting the Birch early. Similarly, some distal conduction disease cannot be corrected by his bundle pacing. So all this can be corrected by left bundle branch pacing. So again, like I said in the previous slide, so you just have to go below the his bundle and place the lead on the right side of the septum. You can see my lead is placed on the right side of the septum. Just pace and see whether you are getting a W pattern in lead V1. Remember, you are not directly on the left bundle. You are on the right side of the septum. Just pace and see the W pattern there. Then just start giving turn by turn. So the lead will go deep inside the septum. So as the lead goes in deep inside the septum, the notch in the W will gradually ascend and ultimately it will form an R wave once the lead reaches the left bundle area. So this is how you do left bundle pacing. Start from the right side, give turn by turn, allow the lead to go deep inside the septum. So once the lead reaches the left bundle branch area, your pace QRS will be looking like from a W pattern to a QR pattern. This is very essential to confirm that we have captured the left bundle. So again, any Brady indication, you can do a left bundle branch pacing, but the main interest is as an alternative for cardiac resynchronization therapy. Remember, the left bundle pacing lead is going to remain stable because you have screwed deep inside the septum, and it is going to give an excellent pacing threshold. Usually, it will be less than 0.5 volt, and the lead stability will be beautiful. So in that way, it overcomes many of the limitations of the his bundle, so that you can produce a beautiful looking QRS at a preferable low output. Of course, not only in a normal sized ventricle, even a dilated ventricle can be targeted by left bundle branch pacing in patients with a non-ischemic dilated cardiomyopathy, where you'll be able to generate a beautiful looking QRS. Another important thing, our beauty of physiological pacing is an acute hemodynamic benefits. This cannot be seen in a BIV device. So for this particular patient had a non-ischemic dilated cardiomyopathy with an EF of around 30%. This is just an immediate post-operative echo done after 7 days, which has shown that a significant improvement in LV contractility. So not only LV contraction, but even this mitral regurgitation has come down significantly over a period of 10 days. You can see here a moderate MR has come down to mild MR after doing a left bundle branch pacing. And this result has happened within a period of 7 days. So this is the beauty of conduction system pacing. This can be demonstrated in both his bundle as well as left bundle branch pacing. But in cardiac resynchronization therapy or by a biventricular device, it will take at least 2 to 3 months to show this a significant improvement in hemodynamics. Not only in LBB, but even an RBVB can be corrected by doing a selective left bundle branch pacing. Of course, atrial fibrillation with fast ventricular rate, previously people are a little hesitant in ablating the AV node and putting an RV apical pacemaker. But here, if you are doing a conduction system pacing, all you have to do is just secure the lead in either his bundle or left bundle, ablate the AVJ, and stop all the rate-reducing drugs, pace the heart for probably for 80 heartbeat for a couple of months, and then you can bring down the rate, and you'll be able to treat the heart failure in a better way as opposed to high-dose medications. Of course, not only as a primary strategy, you can use it as a rescue strategy in patients with a poor CS anatomy, which happens in at least 10 to 20% of cardiac resynchronization therapy devices, where you'll not be able to place the lead safely in a target vein. You can go for either his bundle or left bundle branch pacing. Of course, left bundle is not going to reduce all the dilated cardiomyopathy patients' wide QRS. In some patients, you'll not be able to narrow down the QRS in a better way. Like this patient who had a baseline QRS of 200 milliseconds. After left bundle, the QRS came down to 140, but still the QRS is not looking good. So you can put an additional CS lead, and when you pace both together, you'll be able to regenerate a normal appearing QRS. So if your left bundle pacing alone is not working, probably you can use the help of a CS lead to do what is known as a left bundle branch optimized cardiac resynchronization therapy. So you'll be using an RV lead as a left bundle pacing lead and a CS lead in the conventional vein, and an atrial lead in the right atrial appendage. So we have a lot of evidence supporting the role of left bundle branch pacing as an alternative for CRT. So these are last year's late-breaking trial where we have shown significant improvement in both patients with an ischemic and non-ischemic cardiomyopathy, as well as in patients with an LBBB morphology and non-LBBB morphology. Of course, in patients with an LBB morphology, I'll be the happiest person to do left bundle branch pacing, because if it is a pure non-ischemic dilated cardiomyopathy related to LBBB, what you will label it as an LBBB-induced cardiomyopathy, your left bundle branch pacing using a dual chamber pacemaker is going to produce 100% hyperresponsiveness. So we have shown in at least 13 patients where at the end of 2 to 3 months, all patients had normalization of LV ejection fraction. Of course, like I was talking, this left bundle branch optimized CRT. So if your conventional left bundle branch pacing is not working, you can get the help of coronary sinus lead. You can perform this large CRT. This is presented as a late-breaking clinical trial this year, where you'll be able to show significant improvement in LV ejection fraction as compared to a conventional BIV device. So the search for alternative site to overcome the limitations of RV apical pacing has led to what is known as a physiological pacing. So we have two different modalities of physiological pacing. One is his bundle and another one is left bundle. Remember, his bundle has at least 10 years data, but left bundle has only 3 years data. So we have to wait for the data to support it as an effective alternative for cardiac resynchronization therapy. Thank you for the wonderful opportunity. Thank you, sir.
So what is the biggest limitation? What has to be done to move this field forward? I mean, to bring it to more patients.
Yeah. So regarding this instrumental pacing, so in fact, these two are both are actually complementary. So one should know both instrumental pacing as well as level pacing. For instrumental pacing, the major challenge is having the lead in the instrumental area for LV ejection fraction. But definitely there was a significant improvement in LV in NYHA functional class. So if you have a good number with a good stable lead parameters, and if you can demonstrate the elemental branch capture in all patients, then probably we'll be able to show that this conduction system pacing will work well in patients with RBVB or IVCD morphology. Regarding his model pacing, again, his model pacing, we have data by Dr. Parikshit, so where he has shown that for RBBB correction by his bundle, it's going to produce significant improvement in LV ejection fraction. So, but though we need to have a data comparing CRT versus conduction system pacing, either his bundle or left bundle, so that we need to have a randomized trial. But as of now, we have some promising results. But only thing is that we don't have a good data with the large numbers to support it.
Are you concerns about late dislodgement? I mean, after discharge, leads getting dislodged on left bundle or his bundle. Do you have any concern?
So, yes, sir. So we have done around 220 patients in our lab. This is our single experience. We had 3 dislodgements so far. So one occurred on the next day. So that because of poor anatomy, so the next day we could extract it and replace it. The second thing happened after 2 months. And that was again related to something like a twiddler. But the real worry was the third one, which occurred after 2 years. So we have searched for any evidence for literature report. There was no report of lately dislodgement. It was very unfortunate for the patient. We don't know what is the reason for the lately dislodgement, because still 20 months follow-up, he was having a good capture. It was done for DCM LBBB. So we could recognize that the lead had some micro dislodgement by a rise in his increase in his NYHA functional class and a significant reduction in EF. So his EF was 65 at the end of 20 months. So after 3 months, he came back with an EF of 51% with the exhaustion dyspnea. So that was one thing which was concerned, though we could extract it and place it again in the left bundle area. So that is one thing which we have to again keep in mind, that still lately dislodgement can occur, but it is very rare. So we had only 3 dislodgements in the 220 cases.
I think we have to move on because we are still running so late. Thank you very much again.